Can Crohn's disease and ulcerative colitis actually be reversed? Or do you have to stay on biologics and steroids forever? What are the actual root causes of IBD? And what are the best medicines to fix IBD? How do I know if I'm on the best option for biologics? What about cancer risk? How can I avoid cancer with Crohn's and ulcerative colitis? How do I know my doctor ordered all the right tests? And what natural supplements should I avoid? And which ones actually work? And how do I design a diet and holistic protocol that's best suited for me and for fixing my microbiome? We're going to answer all of these questions and more, so stick around. Hi, I'm Dr. Chanu Dasari, board-certified gastrointestinal surgeon and founder of the Mind-Gut Immunity Clinic. In my practice, I specialize in disorders of the gut, including Crohn's disease and ulcerative colitis. By the time most patients see me for surgery, they've already failed conventional therapy with steroids and biologics, and they're looking for a way to really permanently solve their inflammation. Fortunately for them, I happen to also be a former autoimmune and IBD patient, and I reversed my inflammation without mesalamine, without steroids, and without biologics because I was able to fix the root cause of IBD early on. And no, it's not what you think. There are no miracle supplements or restricted diets. And the truth is, you can't use just diets or supplements to fix IBD. You need to also restore the gut flora with a special technique called microbiome recalibration. Microbiome recalibration permanently restores the balance of gut bacteria and reduces inflammation long-term. And I'll explain how this powerful methodology works later in this video. So in this segment, I'm going to give you an entirely different perspective on how to solve inflammatory bowel disease from the ground up. And if you truly want to get better, I'll show you the classic similarities between Crohn's disease and ulcerative colitis, but also how to leverage the differences in a holistic treatment plan. We will also touch on conventional therapies like mesalamine, steroids, and biologics, and even surgery. But I'm going to go way beyond that and focus a lot of time in this video on how to reverse IBD naturally through my favorite technique, microbiome recalibration. And this is not just another holistic or natural remedy, but an evidence-based, clinically validated methodology developed in the Mind-Gut Immunity Clinic. Along the way, I'll also share with you which supplements to totally avoid. Because there's a lot of people on the internet touting natural cures and buy this product, but some of these are outright dangerous, and some of these are going to surprise you, like turmeric and omega-3 fatty acids. So please watch this video from start to finish because every minute will contain high-impact, actionable items you can use to reverse inflammation for good. Also, before we begin, don't forget to like and subscribe to my channel. If you ever want to speak to me directly about your medical case, I offer discovery calls on my website, mgiclinic.com. Check out the free training videos and resources on how to implement parts of the Mind-Gut Immunity method on your own at home. And there's lots of full-length case studies and interviews with successful patients, so be sure to check that out. It's a great resource. Okay, let's jump in. What are the root causes of inflammatory bowel disease? If you go see a gastroenterologist, they'll tell you it's genetic, and they're talking about human genetics. But most of my clients are the first ones in their families to have inflammatory bowel disease. And even if they have a family history, there could be long periods of time in their life where they don't have manifestations of the disease. So if bad genes cause IBD, why do they sometimes turn on and off? How are they activated and deactivated? And that's where the real question is. The reasons bad genes turn on and cause inflammation are diet, digestion, sleep, stress, and exercise. These all play a role in microbiome dysfunction and poor bacterial genetics. This means that maybe your genes are just fine, and these risk factors are causing your bacterial genome to cause you problems. Here are several research studies that also prove the point. Here is an article from 2019 in the Journal of Nature Microbiology that shows people with IBD lose butyrate-producing bacteria and the microbial genes that make short-chain fatty acids. The reason that's important is because without those fermentation products, the gut lining loses protection and inflammation is more likely to take hold. Here's an article from 2019 in the journal Nature that tracked patients over time with multi-omics and found that disease flares were marked by blooms of oxygen-tolerant bacteria and drops in beneficial fermentation products. The reason that's important is it shows how shifts in bacterial activity, not just presence, directly map onto inflammation. Here is an article from 2014 in Cell Host and Microbe that studied children newly diagnosed with Crohn's disease before any treatment. They found a clear pattern of harmful proteobacteria expanding, while beneficial Clostridia and Bacteroidetes disappeared. The reason that's important is it shows dysbiosis is present right at disease onset, not just a byproduct of medication. Here is an article from 2012 in the journal Nature that showed a high milk fat diet changed bile acids in a way that fueled the growth of Bilophila wadsworthia, a bacterium that produces sulfide and triggered colitis in susceptible mice. The reason that's important is it proves diet-driven microbial metabolism can directly spark inflammation. Here is an article from 1999 in the journal Gut that found ulcerative colitis patients had higher levels of hydrogen sulfide from sulfate-reducing bacteria, and that this sulfide blocked colon cells from using butyrate for energy. The reason that's important is it links microbial fermentation toxins directly to impaired gut healing in UC. Now, these bacterial genes will activate 6 main pathways of inflammation in the colon. And I have an entire video on the pathways of inflammation in IBD where I go into detail about these pathways and how we can fix them individually. So take a look at the link in the description if you want to see these. But to explain the 5 pathways for Crohn's disease and ulcerative colitis, they include the histamine pathway, which is responsible for allergies, candida, and intestinal bacterial overgrowth. Next, there's oxidative stress that damages the liver and causes leaky gut. Then we have the very important arachidonic acid pathway, which is related to cholesterol intake, followed by the salt pathway. And if you don't know by now, salt is very pro-inflammatory and should be limited in the diet. Lastly, we'll be discussing the TNF-alpha interleukin-6 pathway, which is tied to cortisol and how vitamin D works. Now, what are the similarities and differences between Crohn's disease and ulcerative colitis? There are 3 hallmark features of both diseases. Number 1 is body-wide manifestations. We sometimes call this extraintestinal symptoms, meaning symptoms in other parts of the body besides the colon, the rectum, or small intestine. And this can be the lower back, joint pain, like knee pain, hip pain, elbow pain. You can also have dry eye, and actually, dry eye is one of the most common symptoms of IBD. These are eyes that burn or feel dry, brain fog, rashes, fatigue, hair loss, the list goes on and on. Second is abnormal labs. You have iron deficiency due to inflammatory sequestration and blood loss and poor absorption of iron. You can have elevated calprotectin, which the upper limit of the calprotectin is between 50 to 100, but if you happen to have numbers over 250, that's when you get really concerned and have symptoms. You can also have elevated ESR and CRP. Third, you have a biopsy showing inflammation, typically lymphocytic infiltrate. One of the biggest myths that I'm going to correct right now, doctors used to believe that IBD causes cancer. But there's more to the story in my view, and this is simply not the case. 20 years ago, in earlier studies, they saw increased rates of cancer in IBD patients like Crohn's disease and ulcerative colitis. But when they stratified those patients according to how many colonoscopies they had, they found that the absolute cancer risk wasn't significantly higher than the general population. And that's what the most recent data in the past several years have shown. So an analogy would be like, let's say you have 2 groups of people, and in the first group, they get colonoscopies every 10 years, and in the second group, they get colonoscopies every year. Well, the group that gets more frequent colonoscopies will discover more precancerous polyps, dysplasia, and actual cancer. But the overall rates are pretty similar between the 2 groups. Now, I'll create another video describing the cancer rates in more detail, but here's a summary of around 7 studies on the topic. As you can see, the numbers here are minuscule. 0.1%, 0.02% in some cases. So it's important to see this and know you'll probably be fine. And by the way, these studies, you can all reference them. They're listed here. In this video, we're breaking down cancer risks with biologics and inflammatory disease as well. Studies show that anti-TNF drugs like infliximab or adalimumab, especially when combined with thiopurines, carry the highest risk of lymphoma and in some cases non-melanoma skin cancer. But newer biologics like vedolizumab, interleukin-23 blockers, have not shown increased cancer risk so far in long-term studies. The big takeaway? Cancer risk is not the same across all biologics. Older anti-TNF therapies, particularly in combination therapy, show the strongest signal, while newer targeted agents look safer to date. Now, there is an important consideration here. It's the combination biologics and the use of immunosuppressants, which have been associated with cancer progression. Same with steroids. So if the IBD, the Crohn's disease or ulcerative colitis, is active and not in remission, and you are constantly taking these multiple medicines to suppress your immune system, you're probably at greater risk for cancer. So it's better to have Crohn's and ulcerative colitis in remission off medication, then you don't have to worry about increased risk of cancer. And that's very clear from the literature. Now, if you're wondering what biologic for IBD is the best choice, as far as cancer risk is concerned, there are some isolated biologics that don't increase the risk of cancer, and here's a study from the Cleveland Clinic that demonstrates this. So if you have to start biologics because your doctor doesn't know how to fix your problem, then I would suggest one of these. However, just know that any biologics, when combined with other therapies, can cause cancers to progress due to suppression of the immune system. Also, you have major side effects like sinus infection, hair loss, respiratory problems, and depression. All right, moving on. Laboratory abnormalities in IBD. Now, we said earlier there are many similarities between Crohn's disease and ulcerative colitis, such as elevated ESR and CRP, lower hemoglobin, and iron deficiency. We also discussed the calprotectin ranges that produce symptoms. Now, a very, very important difference is in Crohn's, you're more likely to see anti-Saccharomyces antibodies. And I know what you're probably thinking, why do I care? This sounds really complex. Well, this is a very, very important distinction because there's these so-called doctors on the internet recommending Saccharomyces probiotics to reverse Crohn's disease and ulcerative colitis. But I'm here to tell you this frequently backfires in a major way and can cause flares. If you have IBD, and you have antibodies to Saccharomyces, and then you introduce Saccharomyces into the system regularly through probiotics, it's going to perpetuate this autoimmune reaction. So this is a terrible idea. In the Mind Gut Immunity Clinic, we recommend against the routine use of Saccharomyces probiotics long-term beyond just a few days, along with many other supplements that you should avoid. And I'll describe many of these more throughout the video. But this one is just one example of how a small difference between UC and Crohn's can have a major impact and a contraindication to certain supplements. So I said earlier, both Crohn's and ulcerative colitis have chronic lymphocytic infiltration on biopsy. You can also have additional immune aggregates and tissue patterns that are suggestive of one type of IBD versus another. One of the main differences in Crohn's is the increased risk for strictures and fistulas. Strictures are narrowings in the intestine, and the most common places to get these are the ileum, which is the last part of the small intestine just before the colon. The other really common place to get them is at a surgical site. If you happen to have had a section of intestine removed, then the staple line can develop a stricture. Fistulas are abnormal connections between organs, and the most common fistulas in Crohn's are perianal fistulas, which means you get abscesses around the rectal area. Sometimes you can also see fistulas between the bladder, so lots of urinary tract infections. In ulcerative colitis, the inflammation tends to be further down in the colon, so it's easier to see the blood and the mucus in the toilet. This is very relevant because oftentimes we look at daily stool photos for our clients who are enrolled in the Mind Gut Immunity Clinic, and we use these photos to see the stool progress so that we can make adjustments to the regimen. It's easier to see the blood in UC. In Crohn's disease, the blood breaks down, turns a little bit dark in color, so we have to train our eyes and train our clients a little bit differently on how to spot these small changes so that they can make the necessary adjustments easily. By the way, this is just a caveat, but these differences are mainly of historical significance because modern IBD researchers all acknowledge that there is this huge overlap in the inflammatory pathways that are involved. Also, there are newer genome studies for both Crohn's and ulcerative colitis, and basically researchers are starting to agree that there's a lot more overlap. Conventional medical therapies for IBD. The therapies for IBD are basically in 4 categories. First, you have mesalamine. This is basically an anti-inflammatory that works in the intestine. These come as pills, foam, suppositories, and enemas. Next, you have thiopurines. Then you have steroids, mainly prednisone and budesonide. Typically start at a higher dose to stop the immune reaction and then gradually taper down. Lastly, you have biologics. And here's a list of biologics along with their modes of action, as well as some of the side effects. So bookmark or screenshot this section, or you can also go to my website, mgiclinic.com, to download this guide for the biologics. I discuss many of the individual risks and benefits to each and every biologic and how you can make the right choice. Surgical treatments for IBD. If biologics don't work, then there's also surgery. The main reason to do surgery for IBD includes strictures, and these would be long segment, very narrow due to fibrosis, not inflammation, causing intestinal obstructions and weight loss. Surgery for this is called a stricturoplasty because you don't want to remove too much intestine, you want to preserve as much of it as possible. Now, shorter segment strictures can also self-resolve because they're not due to fibrosis, they're due to inflammation. And that's a very important distinction. Second reason to have surgery is dysplasia or cancer. Obviously, if you have pre-cancer or cancer in the setting of inflammatory bowel disease, it would make sense to cut it out. With this type of surgery, you also want to take some of the lymph nodes in the mesentery to make sure that the cancer has not spread. Number 3, intractable bleeding or food intolerance. Some people have such severe symptoms that removing the colon or intestine is an emergency option to save someone's life. Now, I'll just say this is mostly of historical significance before the advent of IV hydration and nutrition. We have TPN right now, which stands for total parenteral nutrition. That basically makes emergency surgery for this kind of thing unnecessary. What are some key empowering tips? What to look for in a good IBD specialist? You want a doctor who has time, isn't rushed, and will listen to your concerns. I've seen people develop IBD following antibiotic treatment, adverse vaccine reactions, H. pylori infections, C. difficile infections, candida, SIBO, bad diets, lack of sleep, stress. All of these factors play a role in the development of the disease. And one of the biggest challenges with finding a good GI is that most of them are quite rushed. They'll see you in 15 minutes, sign you up for a colonoscopy, write you a couple prescriptions, and there are very few of them that will actually analyze what's going on and look at your stool photos and help troubleshoot possible problems. If your doctor just wants to blame genetics and doesn't make any effort towards modifying the diet, identifying trigger foods, or recalibrating the microbiome, they're not following the most recent scientific data, which suggests that all of these things help. So I would say it's time to seek additional expertise in these cases. Next, how do you track your progress with IBD treatment? I would keep a food and symptom diary, and along with this, take photos of your stool and track them each day. You will find patterns and be able to fix them, and you'll notice on the days you get better sleep, for example, your stools will be better, or your energy levels will be higher. If you eat certain foods, you may be triggered and get a flare. So it's really good to track. Third, where can I find good resources on how to fix IBD? I have lots of free resources on my website, mgiclinic.com. On there you'll find a phytonutrient guide, and if you don't know what phytonutrients are, they fall into these categories. These help tremendously in autoimmune conditions and especially with IBD. Also, it's important to realize the difference between fermentable and non-fermentable fiber and resistant starch, especially if you want to rebuild your microbiome from the ground up. It's important to keep these in mind because not every diet works for every person, and there are some key steps for creating a diet that complements and enhances your specific microbiome. All right, I'm going to break down how that mind-gut immunity approach works for IBD. What type of testing should you pursue for Crohn's disease and ulcerative colitis? Well, there's iron studies, and this can tell you if you have iron deficiency or if you're sequestering iron. That's when you have enough iron, but your inflammation is too high to use it properly. You have ESR and CRP. These are markers in the blood for inflammation, and of course, fecal calprotect. Should you get a comprehensive stool microbiome testing? I actually prefer a test called a GI profile. I think the comprehensive stool testing can sometimes be misleading. Moreover, the GI profile, your insurance actually pays for it, so you don't have to pay out of pocket. It checks for E. coli, Campylobacter, Shigella, Salmonella, Clostridium difficile. You can also request the CMV test and a H. pylori test. So you're probably wondering why these tests are more useful than, say, a comprehensive stool microbiome test. Well, for one, they're cheaper because insurance pays for them, and you can do this at any lab like Quest or LabCorp. Second, they're very accurate, unlike some of the other tests out there. Third, whatever problems you identify are actually treatable. You can treat CMV, you can treat E. coli, Clostridium, and H. pylori. Fourth, the comprehensive stool tests, the ones that look at imbalances in commensal bacteria, these are normal bacteria that exist in your gut, but maybe higher or lower levels. And by the way, some of these companies also resort to selling you packs of probiotics to restore the balance, but these tests are totally misleading because they don't look at the individual genetics of the bacteria in your microbiome. Let me give you an example. If you look at Lactobacillus lacti or Bifidobacterium longum, you have the genus name, the species name, But in the world of bacterial genetics, you also have this combination of letters and numbers following the species that designates what subspecies it is, meaning what is the actual genetic code of the bacteria, and that's the most important because these genes are constantly being exchanged by bacteria in the intestines. So the reason these microbiome tests fall short, they don't tell you what the bacterial genes are missing or which ones are overexpressed. They just tell you what species they are and oftentimes send you useless or harmful probiotic because they don't quite understand that this is a concept of bacterial genetics. By the way, testing for microbial genetics in the bacterial microbiome, I think that type of testing is about 5 or 10 years away, and when that becomes mainstream, it's totally going to change the game. This would be a good segue into discussing what types of characteristics you're looking for in a probiotic. What type of probiotic actually impacts IBD, Crohn's disease, and ulcerative colitis? Number one, you're looking for a probiotic that's acid resistant, meaning it can survive digestion. You also want bacteria that can ferment appropriately. We're talking about fructose, lactose, and oligosaccharides. These would be the higher FODMAP foods. You want a bacteria that also reduces inflammatory markers like TNF-alpha, interleukin-6, histamine. And you want a bacteria that lays down a competitive biofilm to push out bad bacteria. So if you can imagine, 99.99% of all the probiotics out there are going to be totally useless for fixing this problem, because they don't meet these 4 criteria. All right, back to testing. Heavy metal testing, useless. Most people have the same level of heavy metals in their system when they were diagnosed with inflammatory bowel disease and after they get diagnosed. So this is not a very significant contributor as far as I'm concerned. It's probably ranked number 20 or 30 behind several dozen other variables. Dutch testing for hormones. This can be only sometimes useful for identifying adrenal fatigue from undereating or things like SIBO and other types of bacterial overgrowth. Leaky gut testing, pretty much useless because it tells you what you already know, that you already have gut microbiome dysfunction and as a result, leaky gut, which means inflammation is really causing damage to the intestine. And by the way, you don't need a leaky gut test to know this. You already have a test that shows inflammatory bowel. SIBO and a Candida test. These are basically useless because they tell you what you already know. Again, falls under the broad umbrella of gut microbiome dysfunction. Mold testing. I would put this as somewhat useful, especially if you have a chronic exposure in your home or your workplace. The problem with this, however, is that you don't actually know how much of this is probably contributing on a day-to-day basis. I'll also tell you it's more important in other autoimmune conditions like eczema or lupus. It can play a role in IBD, Crohn's disease, and ulcerative colitis too, but I would put this further down on the list. Food sensitivity testing. I would put this as sometimes useful. The 2 types of tests that are probably the best ones to get are IgG4 or LEAP MRT, and I'm partial towards the LEAP MRT for various reasons. The timing of this test matters because you'll have false positives and false negatives, which need to be tested further. Also, one of the limitations is that it doesn't take into account the fermentation problems. So I'll sometimes order these tests in month 2 or month 3 of the program, but in 90% of my clients, they never end up needing these tests because they keep a pretty detailed food diary. And even after you do these food sensitivity tests, you still have to keep a food diary to figure out if a food is actually causing a problem or not. Also, the biggest mistake people make is trying to get one of these tests when they're in a flare. When you're in a flare for Crohn's disease or ulcerative colitis, you can get a lot of false positives on this test. So they're not generally very accurate in the first month. I prefer to decrease the inflammation first, wait a month, and then decide whether the testing's actually needed or not. By the way, these are called functional tests, and you can't find them at a typical doctor's office, and sometimes these alternative or holistic or naturopaths will charge you thousands of dollars to run these tests, then sell you a bunch of supplements. So don't be fooled. Do your due diligence before throwing away your resources at these not so helpful tests. Diet and IBD. Big bad foods to avoid. Complex proteins, these would include things like casein, bovine, gluten. We have nightshades like tomatoes, peppers, eggplants. They have this thing called solanine alkaloid that causes leaky gut. Processed wheat products, chemicals, preservatives, sugar alcohols. Dairy, which includes lactose, but also casein and fermented dairy products. The best diets are whole food plant-based diets or Mediterranean diets are also useful. And as you know, I'm well known for a diet called the phytonutrient diet, or phyto diet for short. And that's because in IBD patients, There are several key nutritional deficiencies. The most common nutritional deficiencies in IBD, from a vitamin standpoint, you have vitamin D, vitamin B12, and that's because 80% of the population are undermethylating. They have an MTHFR gene mutation. Mineral standpoint, you have magnesium, iron, and by the way, a lot of doctors prescribe oral iron for IBD patients, and that's for Crohn's and ulcerative colitis, but I'm here to tell you that's not always a great idea. Here's a study that shows iron oxidation in the gut can make inflammation worse. And here's another study that looks at iron's effects on gut inflammation. So even though this is listed here as a common deficiency, I would tell you it's better to get an iron infusion rather than take oral iron supplements each day because it makes your inflammation worse. All right, the most common nutrient deficiency in IBD patients is phytonutrients. And that's why the diet that I put all of my clients on is called the phyto diet. It's rich in phytonutrients. These include things like polyphenols, terpenes, thiocyanates, resistant starches, fiber, omega fatty acids. Every single one of these categories is deficient in people with Crohn's disease and ulcerative colitis. So if you're designing a diet around these key concepts, I would tell you to maximize each category, and that's where the phyto diet really shines. It fixes the key nutritional deficiencies seen in Crohn's disease and ulcerative colitis. Now, you would think that phytonutrient supplements are a good idea, but there are some key supplements that you should avoid. What supplements are dangerous to take if you have IBD, Crohn's disease, or ulcerative colitis? Turmeric and ginger, I would use boswellia instead for joint pain. Omega-3, I would use omega-9 instead. Butyrate, these are short-chain fatty acids, also called postbiotics. I would use fermentable fiber as an alternative. Vitamin K. Probiotics, if you take the wrong one, you can create more damage. So I'm going to go through each one of these one by one. Turmeric and curcumin. Most people think it's great for IBD, but in reality, it thins the blood. Same story with ginger. Omega-3, while it's helpful for people with other types of autoimmune disease, if you're bleeding from your intestines, it's not a great idea to take something that thins the blood. Omega-9 fatty acids are better, so think olive oil, almond butter, or avocados. I've also seen these products on the market called postbiotics or butyrate. They're made of butyrate short-chain fatty acids. Now, the colon actually survives off of these short-chain fatty acids. So if you want a healthy colon, you need to have butyrate in your colon. But if you think that ingesting butyrate orally is a good idea, you've been misled because the short-chain fatty acids that are consumed orally, they just get broken down and absorbed and never reach the colon. In fact, most of the short-chain fatty acids in the colon are made by gut bacteria. They ferment fiber and they make butyrate in the colon. So eat fiber. Don't take butyrate or a postbiotic unless you're considering an enema, because short-chain fatty acid enemas are the only thing that actually work. But then you're dealing with an enema, and there are far better options out there than enemas. Vitamin K. This one's a bit controversial. There are a lot of people that take vitamin K2 in combination with D3 thinking it improves absorption and helps keep calcium out of the arteries. But my experience on this is that vitamin K is produced in the gut by gut bacteria, and most people besides newborn babies are not deficient. Once you restore the microbiome, it will produce healthy levels of vitamin K, so you don't need to take more. Key lifestyle strategies. Sleep. We want 9 hours of restful sleep. If you get less, then you should try to get more. Now, I can get into this further, but if your sleep is insufficient or you have a condition that affects sleep, like sleep apnea, for example, then your inflammation goes up due to cortisol release. So this is a very, very important focus of our program, is to find ways to maximize sleep. Stress and trauma. This may be a touchy-feely topic, but suffice it to say, 100% of the people I work with have ignored their health due to some obligation. Exercise. We want resistance weights 2 to 3 times per week, and then maybe something like walking or swimming daily. Okay, that was a long video. Save and bookmark this because I know you'll want to refer back to this once again later. I have additional resources on my website, mgiclinic.com, to help get you started with this holistic protocol for IBD, Crohn's disease, and ulcerative colitis. The Mind Gut Immunity Clinic specializes in fixing gut microbiome dysfunction and restoring the colon and intestines to normal function. Lastly, don't forget to like and subscribe for more videos such as this. And you can always request a discovery call to speak to me directly about your case. This is Dr. Chanu Dasari with the Mind Gut Immunity Clinic, and I'll see you next time.